All right, good afternoon, everyone. It is 12:30 on the dot, so we're going to go ahead and get started. My name is Janelle Peterson. I'm the Director of Communications and Training here at the Alliance, and we are really excited that you have joined us for our webinar today on improving screening and referral for oral health care in pregnancy. Just a few housekeeping items before we get started. All lines will remain muted to avoid background noise, but we do want you to engage in the presentation. So please send questions or comments through the chat or the Q&A function, and we will address those at the end of the presentation. A copy of the slides and the recording will be shared after the webinar takes place. And then we will have a post-webinar evaluation, so please fill that out. It's just 3 or 4 questions, very brief, but we really value your feedback. I'm excited to introduce Dr. Elizabeth Wood. She has been an OB nurse for 6 years and recently graduated with her doctorate in nursing practice, specializing in women's health. And she's currently working at a clinic on the Salt River Reservation. She's going to talk about a project she did for her DNP program, and really excited to have her on this webinar. So Dr. Wood, I will pass things over to you.
Thank you for the introduction, Danelle. I'm going to, can everyone see that?
Yes, we can.
Okay, wonderful. So as Danelle said, I'm Elizabeth Wood, and I graduated from ASU with my DNP in women's health. And I completed this doctoral project that I'll be discussing today. And it's about improving the screening and referral process for oral health care in pregnant people. This is a topic that I am very passionate about and actually stems from personal experience. I have 2 children. When I was pregnant with my first 10 years ago, my provider did not discuss oral health care before or throughout my pregnancy. However, I happened to be due for several dental cleanings and minor procedures during this pregnancy, of which I completed without any issues or thought. With my second pregnancy, again, oral health was never addressed, and I knew I had a cavity or 2, but life with a toddler and a full-time job gave me all the excuses not to go to the dentist during my second pregnancy, and I continued to put it off even after delivery. With both children, we have always provided the proper dental hygiene and had them see the dentist at the recommended times. My first has had 1 cavity in her 10 years. By the time my second was 3, he had had 1 tooth pulled, 2 silver caps placed, and 2 cavities filled. It wasn't until I began my research for this project that I realized that 1, how overlooked oral health in pregnancy is, and 2, how important it is that providers, OB and dental, address it. Oral health is important to our overall health. Oral health disorders are associated with many disease processes, such as cardiovascular diseases, diabetes, Alzheimer's, and respiratory infections. Hormonal and immunologic changes during pregnancy can exacerbate inflammation of the gingiva, increasing the mother's chances for developing periodontal disease. Oral health status also plays a role in not only pregnancy outcomes, but in the future dental health of the unborn child, yet it continues to be overlooked in the perinatal period. Vulnerable populations are at highest risk for adverse outcomes related to poor oral health, and complications in pregnancy from poor oral health are absolutely preventable if more providers and patients are made aware of the risk factors. Some form of periodontal disease is seen in nearly 40% of all pregnant persons, and 60 to 70% of pregnant persons have gingivitis, which is an early stage of periodontal disease. If this is left untreated, it can lead to oral bone loss and infection of the gums. Poor oral health can also lead to the growth of bacteria that can be passed to the infant through common behaviors such as spoon sharing. Affecting the most vulnerable populations, this is a silent epidemic in the United States. And in Arizona, comprehensive dental coverage for pregnant people 21 years and older is not covered by Medicaid. This is a graphic that depicts the barriers encountered by people when trying to seek dental care. While there are several barriers, the focus is on insufficient prenatal and dental coordination of care and referrals. Therefore, the purpose of this project is to improve the screening and referral process for oral health care to pregnant people and increase interprofessional collaboration. These organizations have stated that dental care in pregnancy is safe and recommended, and Healthy People 2030 aims to increase access to and use of dental services, as well as the American Academy of Pediatrics. They also put forth an initiative to increase oral health care during pregnancy in order to reduce childhood cavities. For this project, I partnered with the Arizona Alliance for Community Health Centers, and they have actually been a constant partner throughout the 3 phases of this project. This was a 3-year legacy project. My colleagues who preceded me completed gap analyses to obtain the internal evidence to understand in this system of clinics the factors that facilitate and prevent access to oral health care during pregnancy. This included surveys for both prenatal and dental providers to assess knowledge, beliefs, and behaviors. The result of their work provided the evidence that I needed to guide my part of this project. What was found was that there was no standardized oral health screening being done. There's also a lack of collaboration between prenatal and dental providers and concerns among dental providers related to the safety of treating pregnant people. There was also no formal training for prenatal providers for assessing oral health status. All of these were found to hinder the receipt of oral health care during pregnancy. So then this inquiry led to the PICO question: in persons seeking prenatal care in a community health center, how will a oral health screening tool versus no screening tool improve the receipt of dental care during pregnancy? The evidence synthesis was completed using these keywords you see on the screen. I won't list them all, but they're there. And then 10 articles were critically appraised with levels of evidence ranging from 1 to 4. Throughout the literature, a common problem was that providers are not discussing the importance of oral health during pregnancy, and pregnant people are not being referred for dental services. The evidence supports that the use of a standardized oral health screening tool embedded into the electronic health record, or EHR, and interprofessional collaboration between prenatal and dental providers are the initial and essential approaches to improve oral health care delivery during pregnancy. The theoretical framework used to guide this project was the ecological model for health promotion. It has 5 levels that are determinants of behavior change. This project focuses on the interpersonal processes related to the collaboration of care between prenatal and dental providers, as well as the institutional factors. That is the implementation of a standardized screening tool into the EHR and a referral process streamlined between prenatal and dental departments. The implementation framework used was the oral health delivery framework. This aligns with the aim to improve access to oral health care. Although this model was designed for primary care providers, it can be applied to the prenatal setting. When providers in women's health or prenatal providers also provide a broad spectrum of care, including general health promotion, interval care, routine and preventative screening, and treatment for acute, uncomplicated illnesses, they are practicing within the realm of primary care. For that reason, this model was an appropriate guide for this practice change this project aimed to accomplish. This project received expedited IRB approval through Arizona State University, and the participants included prenatal providers such as physicians, nurse practitioners, as well as medical assistants. Staff attendance to a training meeting and acceptance of a participation letter implied consent to participate. The setting was at Sun Life Family Health Centers, where both prenatal and dental services are available. And the intervention was the addition of a standardized screening tool into their EHR. The maternal oral screening, or MOS tool, is a validated tool that consists of 2 questions, as seen here. It was, I was given permission to use it by the author. And after IRB approval, the tool was added to the prenatal provider's EHR system. Training was provided to all participants via a voiceover PowerPoint, and a participation letter for each role within the project was also provided. This is what the screening tool looks like in the EHR. And the questions are in the physical exam section with drop-down boxes based on the patient's answers to each of the questions. The medical assistants were to screen every new OB patient that was less than or equal to 26 weeks gestation and document the answers in the EHR. If the response was yes to question 1 and no to question 2, a dental referral was needed to be generated. This was the timeline that I used for the project. After the approval and addition of the MOS tool into the EHR, data collection was done over 8 weeks. Data was collected via de-identified aggregate EHR reports, and data collected included the number of new OB patients seen, how many were screened, the number of positive screens, and the number of referrals generated from those positive screens. Then descriptive analysis was used to analyze the data. A total of 137 new OB patients were seen over the 8-week data collection period, and 125 of those patients met the criteria to be screened using the MOS tool. Of the 125, 101 or 80.8% were screened and 24 were not screened. Of the 101 who were screened, 71 persons screened positive based on their response to the MOS tool questions and should have been referred for dental care. After determining that 80.8% of the eligible patients were screened and 71 were positive, we found that 11 of the positive patients were referred for dental services. The rate of compliance with referrals was low compared to the number of clients that were screened positive for a need for dental care. It may be related to the task being a new step for the staff and a short intervention timeline, or it may have been related to dental care not being covered, a covered service, and perhaps more time and continued regular feedback on performance. The referral rate may have increased. The results of the project were clinically significant because it led to a practice change with the addition of the MOS tool into the EHR and 80.8% adherence with the use of the screening tool with each eligible new OB patient. And it also led to some dental referrals to dental care for pregnant people who met the referral criteria. As far as the impact of the project, for the patients, it starts the conversation about oral health in pregnancy, and those with concerns and based on the screening answers can be referred for dental services. For the providers, it is an easy standardized tool to use during routine new OB visits. And for the overall system, it is a sustainable option that standardizes practice and can be implemented throughout all of the federally qualified health centers. This project can also be a driving force for advocacy and policy changes around comprehensive dental insurance coverage during pregnancy under Medicaid. Strengths and facilitators of the project include the MOS tool embedded into the EHR and 80.8% compliance among medical assistants with the use of the tool. And site champions really taking charge, making it a sustainable intervention. The tool can easily be used for in-person and virtual visits, although for this, it was only used during in-person visits. Limitations included less referrals generated compared to the number of positive screens. And this could be because generating referrals is a separate task for the staff and could have been forgotten or missed or submitted improperly. Also, this was a new practice change, and there's always a learning curve with those. The absence of a standardized technology-based process for retrieving data from the EHR made it difficult to obtain other meaningful data points, such as dental appointments made and kept after the receipt of the referral. And finally, the limited data collection period prevented the ability to track dental appointments made after receipt of the referral and to document the increase of interprofessional collaboration. So according to the literature, and what we found is that the MOS tool is transferable and easily incorporated into other prenatal provider EHR systems. We also found that oral health screening does lead to an increase of referrals for dental services, and it follows professional guidelines to screen and recommend dental care during pregnancy. Recommendations for future quality improvement projects include the development and installation of programming within the EHR that would facilitate accessing data to track appointments made and kept for dental care, and document interprofessional collaboration and comparison of outcomes for pregnancy and child dental health in clients who obtain treatment for periodontal disease in this federally qualified health center. The adherence over time to screen with the MOS tool and referral for dental care, as indicated, would confirm a sustained practice change. Any cost-benefit analysis related to the intervention could provide information that would persuade policymakers to consider requiring health insurance vendors to include dental care during pregnancy as one of the criteria to be included as a qualified insurance plan in the state Medicaid program. In conclusion, dental care is safe and recommended during pregnancy to reduce the risk of adverse birth outcomes and poor oral health in children. The results of this quality improvement project align with the outcomes of research about effective strategies to increase oral health screening during the first half of pregnancy. The MOS tool embedded into the EHR is an evidence-based strategy to identify pregnant persons in need of dental services and encourage interprofessional collaboration. And for this project, I am very grateful for all of the support I received from my mentor, Dr. Link at Arizona State University, as well as Kyle McDevitt at Sun Life. She was my site champion and absolutely wonderful. And of course, Janelle Peterson has been very supportive through all of this as well. And I can answer any questions that anyone has at this time.
Awesome. Thank you so much, Dr. Wood. We do already have several questions.
Okay.
The first one is, just find my chat again, is from someone in Nebraska. Their Medicaid agency is getting ready to add dental on October 1st. So they're curious if the MOS tool is something that can be used without approval. I know you mentioned you got approval. Do you know if it can be used without seeking approval?
That's good to know. Actually, I'm not sure. I mean, it's two easy questions just to add to when seeing any pregnant person. As far as adding it to the EHR, I'm actually not sure if you would need approval for each time. I needed approval to include it in my project, so writing it out, giving the author credit. But I'm not quite sure on that. That's a good question.
It is a good
I
question.
will look
Yeah.
into that though.
Yeah, I will
Because
too.
now I'm curious, because the whole goal is to integrate it into more EHRs throughout the federally qualified health systems. And so I will look into that.
All right, thank you. And I can't remember if you mentioned this, the EHR that Sun Life is on, just so the audience knows.
Oh my gosh, I just blanked on it.
I think it's eClinical
Yes,
Works.
yes,
Okay.
ECW, eClinical Works is that. And eClinical Works, talking to a lot of centers, eClinical Works seems to be the easiest so far to implement this tool. I think it depends on which EHR you use and how easy it is, or where the tool actually goes into.
Thank you. The next question is, was a visual screen of the oral cavity done in conjunction with the questions that were asked?
Good question. And no, there wasn't, because providers, it's not a normal thing in prenatal provider training to do that. And we didn't provide that kind of training for this project, but that is something I feel like would be really useful to use in conjunction with the screening tools. But the providers would need training for that.
Thank you. And for the 60 who were not referred to a dentist, what was the primary reason given? I know you talked about a few, but.
Yeah, we weren't able to really follow up with the providers after this project. This project was only 8 weeks long. We were kind of on a time crunch as far as my graduation went. So getting feedback from the providers afterwards as to why, exactly why referrals weren't done for those patients, I wasn't able to get that. We didn't do a pre or post survey with the providers at this particular site. And so I wasn't able to get details as to why the referrals weren't done for those ones.
Thank you. And then the next question is related to follow up with the providers as well. So I don't know that you'll have an answer for this one either, but they were just curious if there was something that made the providers who did refer, their motivation for making that referral as opposed to the people who didn't. Did they have a provider that they had a relationship with and were familiar with, and that made the referral easier? So I don't know if you have any insight there.
Just my site champion was one of the providers who saw the prenatal patients. I forgot how many providers were there to see all the pregnant patients, but she was motivated by my project itself to refer, but otherwise I'm not sure what was the motivating factor. I think that is a huge part of continuing this, is talking with the providers, following up with the providers, and this can be a whole nother project too, to find out exactly why, even with the tool and the questions being asked, why weren't referrals generated, or why did you feel motivated to generate referrals after that?
Yeah, I like the person who asked the question. I like their suggestion that maybe it was about relationships. If the dental providers and the prenatal providers had good relationships, they're more likely to communicate, more likely to refer patients. So yeah, it would be a really interesting follow-up.
And with this particular site, sorry,
no, you're fine, please.
I think there's several sites that see prenatal patients, but only one of those sites has the dental providers at the same place or in the same building. So I think the ones who are kind of distant, that relationship might be a little harder. Yeah,
great point. The next question is, any ideas of advocacy as next steps based on the data?
Well, perhaps presenting this to, I made a few connections with some representatives, some state representatives that I'm hoping to maybe present this to kind of advocate for dental coverage. And then maybe go from there. Also presenting at a conference, if that opportunity comes up, to reach out to more providers. That's it so far as my plans go with this.
Yeah, I think those are great ideas, Dr. Wood, and we can certainly here at the Alliance use the data and some of our advocacy efforts as well. We've been advocating for adult dental for quite some time, and the pregnancy population is a starting point. So hopefully we can use this data for some of those ongoing efforts here in Arizona.
Yes, that's my hope. There has been a bill, I think, that was introduced in 2017, and it just keeps getting vetoed. And so I spoke to some of the representatives in favor of that bill. So I'm hoping to build relationships with them or continue to build those relationships and hopefully get more coverage.
Awesome. I'll give it another 30 seconds or so to see if anybody has any last minute questions. Really great questions, everyone. So thank you for your engagement.
Yeah, I appreciate them.
Bernice, while we wrap up, if you'll go ahead and put the link to the post-webinar. Oh, we got a question. You can still go ahead and put the link to the post-webinar evaluation in the chat, but we did get another question. Through a grant from First Things First, we are screening expectant mothers for oral needs. How would you recommend beginning the conversation with medical providers and clinics?
That's a good, I love that First Things First program. I've read about it. How to begin? I mean, I guess kind of how I approached with this project is just start with a simple presentation about why oral health is important. And the biggest correlation was poor oral health and poor oral health in children. And so I think just emphasizing the importance of oral health in pregnancy and I guess take a non-threatening approach, but just really encourage the screening and talk about really how it just takes a few minutes to start the discussion with the pregnant person in your office. And it can be part of routine. We have a lot of conversations with pregnant women when they're coming in so routinely, and it's a great opportunity for providers just to mention it. So maybe go about it that way. It's just really easy to implement some kind of oral health conversation with each patient that they see. If that answers the question.
It did, yeah. And I think the way you started out the webinar is great too, talking about your personal experience and having a champion that can do that. You mentioned your champion at Sun Life. I think finding a champion who can talk to providers kind of peer to peer is always really helpful as well. So
site champions are wonderful.
Yes, absolutely. Well, thank you again, Dr. Wood, for sharing this information on the project that you did. I don't think anyone from Sun Life is on the line, but thank you to Sun Life for partnering with Elizabeth on her project and ASU for their support along the way.
Thank you for having me.
Yeah, absolutely. It was our pleasure. I know Bernice put the link to the evaluation in the chat, and I just encourage everyone to check out our website for other learning opportunities that we have coming up. And just, I hope everyone has a great rest of your week. Thank you again for being here.
Thank you.